My name's Neil Fenn. I'm a consultant neurological surgeon at Swansea Bay University Health Board and HMT Sancta Maria Hospital in Swansea. I have a specialist interest in Uro-Oncology, mainly prostate and kidney cancer. The prostate gland is an organ which sits deeply in the pelvis, below the bladder. It surrounds the urethra, which is the tube which drains urine from the bladder to the outside world. The main function of the prostate gland is to produce various chemicals and secretions which come out in the ejaculation, and they support sperm in the process of fertilization. Despite the fact the prostate is relatively small and tucked deep in the pelvis, it does tend to be affected by a number of different conditions which cause problems for both patients and then obviously requiring medical intervention. The commonest thing we see is an age-related benign non-cancerous enlargement of the prostate, which we often call BPH, benign prostatic hyperplasia. Because the prostate sits around the urethra, this enlargement will start to inhibit the flow of urine from the bladder, and patients will complain of symptoms such as hesitancy, a poor flow, and then some post-voiding dribbling. As time goes by, because the bladder has to push harder to get past the obstruction, patients start to complain of post-voiding dribbling. As time goes by, because the bladder has to push harder to get past the obstruction, patients start to complain of storage symptoms, which include frequency, urgency and nocturia. It's this group of storage symptoms that cause most bother to patients and tend to inhibit or interfere with sleep patterns and daily activities and bring them to see their general practitioners. The second group of patients we see with the prostate are those that are suffering from prostatitis. This is an unusual diagnosis and results in a constellation of symptoms, mainly related to symptoms within the pelvis such as discomfort and pain, and cause the patient's issues which are often long-standing and relapsing. The final group is the group of patients who develop a prostate cancer. Cancer is an uncontrolled growth of the cells of a tissue of a particular organ, in this case the prostate, and this will result in a growth initially within the prostate, and then, if left unchecked, will subsequently expand or extend out of the prostate and to other areas. Fortunately, however, advances in diagnosis and treatment mean that up to 90% of men diagnosed with prostate cancer will still be alive and well at 5 years after diagnosis. So we spoke earlier on about BPH, the benign prostatic hyperplasia. This is a common age-related phenomena, as we've already pointed out, with up to 50% of 50-year-olds suffering from an enlargement, a benign enlargement of the prostate, which will extend into most people between 80 and 90 having this problem. The symptoms, those lower urinary tract symptoms we mentioned earlier, do tend to cause bother for the patient. If you are suffering from these symptoms, your first port of call would be to go and see your general practitioner. It's likely they will assess you by taking a history. They'll also examine you, which will include an internal examination of your prostate via the tail end that we would term a digital rectal examination. Provided they find no issues with the prostate that would make them concerned, it's likely that they will do one or two blood tests, a kidney function test, and I'll also discuss a prostate-specific antigen blood test, which is a test we use to help us define which patients have a benign enlargement of the prostate and those that may have a prostate cancer. For those men in which those results are normal, the tail end examination plus the blood test, then your general practitioner is likely to discuss a number of lifestyle changes that can be made to try and improve your urinary symptoms, and they will also discuss various medications. The two broad groups of medications we try with men who have a benign enlargement of the prostate are the so-called alpha blockers. This is a group of medication you take on a daily basis that will relax the prostate and help improve the flow and ultimately reduce the storage symptoms. The second group of tablets are called the 5-alpha reductase, of which the commonest drug is finasteride, and this group of tablets actually shrink the prostate over time. And we often use those two tablets in combination to produce an immediate or rapid response with the alpha blocker, and then a more long-standing improvement with the 5-alpha reductase inhibitors. Of course, not all patients will see an improvement in their symptoms, or in fact they may have an improvement and then their symptoms progress. And in this group of patients, we would need to consider more involved treatments, which are mainly surgical treatments. This is one of the big expansion areas at present within the management of benign prostatic enlargement. And essentially, there are a whole raft of different surgical treatments, which we broadly split into 3 groups: the so-called MISTs, the minimally invasive surgical treatments. And at Sancta we're able to offer a steam treatment called Resume to the prostate. Then the middle ground are those patients that we would treat with the traditional so-called TURP, which is a general anaesthetic operation to create a new channel through the prostate. And then if you have a very large prostate, which fortunately is only seen in a handful of patients, we may need some specialist treatments such as a holmium enucleation procedure. So if the medication that you're started on by your general practitioner fail to improve your symptoms or improve them and then they progress afterwards, then you'll tend to be referred in for a specialist opinion with a consultant urologist. When you see that consultant, what will happen? They will just go through the history again and the examination, review the tests that have already been done, and then they will arrange some specialist investigations. One of those is a flow rate and a residual volume. So we'll actually get you to void into a machine that we can measure the pressure of your flow so we can get an objective assessment of just how bad it is. And then you'll also be scanned after that with a bladder scanner to see if you're holding on to any urine that you don't void out. Occasionally you'll also require a visualization of your urinary tract with either an ultrasound scan and or a flexible diagnostic cystoscopy, which is where we look into your bladder. With those investigations, we're able to really work out whether patients need to progress from tablets and medication onto the surgical treatment for their BPH.